This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So I'll start with disclosing I have no conflicts of interest. So I want to just remind us before we get into the controversies of cancer screening is just sort of what the definition of screening is. And so screening in general is the investigation of a large number of something, such as people, to look for those with a particular problem or feature. And in medicine, it's a strategy that we use in a population to detect those individuals who might have a disease but who don't have any symptoms. This is very important. For example, when we're talking about breast cancer screening, if a woman has a breast lump or she has a breast mass, that's not screening, that's evaluation. If somebody's having a colonoscopy, for example, because of abdominal pain, that's not screening. So I just want to remind ourselves that screening is just people who come in feeling totally fine, and we're thinking about what tests they might need just to look for particular diseases. What are the things we think about when we think about screening for a disease? Well, first of all, the disease needs to be common in the population. We don't screen for things that are very rare because, as you can imagine, you have to screen a lot of people to find one case of the disease. We'll talk a little bit about this when we talk about ovarian cancer screening. Secondly, the disease needs to have serious consequences. We don't screen for the common cold because by the time we found it and decided what to do about it, it would be gone already. Very importantly, the disease needs to have what we call a detectable preclinical phase, and that means a time during which you can find something with the screening test, but the patient hasn't yet developed symptoms. So for example, an abnormality found on a mammogram before the woman has symptoms, or an abnormality found on a pap smear when the woman doesn't have any symptoms. Hand in hand with that is that treatment for that pre-symptomatic disease, the disease that you found by screening before the person had any symptoms, needs to be more effective than waiting until after the symptoms develop. And ideally, we want tests that are simple, inexpensive, and acceptable with a high sensitivity, which is the ability to find disease in people who have it, and a high specificity, which is the ability to have a normal test in people who really don't have the disease. So how do we know if a test works? So we need to know not just that the test can find more cancer, because as you can imagine, lots of tests will find more stuff. The more tests you do, the more things you will find. We need to know that early detection reduces the chance of dying from that disease. Not just that it'll find more of the disease, but that it reduces your chance of dying. Ideally, we want to have very few false positives, and I imagine there are probably a couple of women in this room who have gotten a phone call back because of an abnormality on their mammogram, who needed to go on to have additional testing, maybe additional views, maybe an ultrasound, maybe even a biopsy, just to find out that they didn't have cancer. So ideally, we don't want to have too much of that happening. And where do we get our evidence about effectiveness? Well, ideally, we like in medicine what are called randomized controlled trials, where you have a group of one people who get the test, a group of another people who don't get the test, follow them forward in time, and see whether or not there's a reduced rate of mortality. As you can imagine, those studies are expensive, take a long time to do, but that's the ideal way we want to get our information. But sometimes we can get information from other types of studies which are easier to do, such as case control studies. There are some potentials for bias, and the most important one I want to talk about is something called overdiagnosis. This is something that comes up a lot with mammography and with prostate cancer screening, where you find cancers that may not ultimately have become aggressive cancers, but once you find them, you have to do something about them, and you only found them because you screened. Other things to think about. So often we think about sort of widespread screening. For example, everybody over the age 50, we should be thinking about colon cancer screening. and that's when the risk of a disease goes up with age. Sometimes we want to think about screening in high-risk groups, and we'll talk particularly about that tonight when we talk about lung cancer screening. We don't necessarily need to screen everybody for lung cancer, but there are new recommendations for screening individuals who are at particular risk. And then very importantly, particularly where it's not entirely clear what the right decision is, and we'll talk about this a lot with prostate cancer screening, is involving patients in the decision. Rather than me just ordering the test and saying go ahead and go, talking about the pros and cons of the test, what other comorbid conditions does a patient have, what's a patient's life expectancy, would he or she want to undergo treatment, how would he or she feel about false positives. So let me just tell you what some of the controversies are that we're going to discuss this evening. So first of all, just sort of what are the expectations of screening? Breast cancer screening, we'll talk about whether screening reduces mortality, who should be screened, and a little bit about 3D mammography. Cervical cancer screening, there are some relatively new recommendations in the past few years. Colorectal cancer, the question goes on about what tests someone should have and how often they should have it. What about some of the new screening options? Lung cancer, as I mentioned, does screening work? What about chest x-ray? What about low-dose CT? For prostate cancer, the big question is, should we screen at all? And finally, ovarian cancer, should we screen? So this was a fun study just looking at the public's enthusiasm for early cancer detection. This was a national telephone survey of adults, 500 men and women with no history of cancer. And what they found was that 87% of respondents to this survey believed that routine cancer screening is almost always good. Less than 1/3 of individuals believe they will ever stop screening. And this is very interesting because we're sort of in this era now of realizing that there probably is a time to stop screening certain individuals for certain diseases. This one amazes me. 2/3 would be tested for a disease even if nothing could be done. Mrs. Jones, I screened you and we found this really bad disease, but we can't do anything about it. 2/3 of people would be tested, and 73% of individuals would like a total body CT instead of $1,000. Okay, so let's turn to our first area, which is breast cancer screening. So as you know, breast cancer is the most common cancer in women, second leading cause of cancer death. We've had evidence prior to this that screening mammography can reduce mortality from breast cancer. There's been a lot of controversy about screening in younger women, and we'll talk about that a little bit. And the biggest reason for this, or one of the big reasons for this, is that the biggest risk factor for getting breast cancer, in fact, for getting any of the cancers we're going to talk about tonight, with the exception of cervical cancer, is just getting older. So women in their 40s, for whom there's some controversy, have lower breast cancer risk. And so you have to screen a lot more women to find one breast cancer. And as you can imagine, there'll be a lot more false positives in that age group. The other issue for younger women is that younger women have denser breasts, and the way that we see an abnormality in a mammogram is as a density. So it's just harder to see density within density. So what are some of the harms, the potential harms of screening? So false positives. I make probably at least 1 or 2 phone calls a week to a patient who has an abnormal mammogram, and it could be a minimally abnormal to a very abnormal mammogram, and there can be varying levels of anxiety. Women will assume this must mean I have cancer, and what am I going to do? And you know, different women have different feelings about this, but it can definitely cause anxiety. How soon can I get my test done to get this answered? Can lead to additional tests. Sometimes it's just additional views or additional ultrasounds, but sometimes it's a biopsy. And of course, it can cost more. Overdiagnosis, I alluded to this earlier, but these are cancers that are diagnosed that never would have caused symptoms, never would have come to the fore, except that the woman had the mammogram and now the cancer has been seen. And this has been estimated to be up to 1/4 of all invasive breast cancers. And there's a small risk of radiation exposure. So I think just when we think about screening in general, we always want to think that there are some definite positives, but depending on the screening test, there are some potential negatives as well. So let's talk about the guidelines for screening. So the first set of guidelines, and I'm really going to emphasize these for most of the evening, is something called the U.S. Preventive Services Task Force. This is an evidence-based organization that comes together to make recommendations. They have multidisciplinary input, and they really primarily focus on the evidence. As you know, they're not the only organization that makes recommendations, and any organization can and will make recommendations, and they're not always the same. But I want to just focus on those to start with, and then I'll tell you about some of the other recommendations as well. So first of all, for mammography, they recommend for women aged 50 to 74 screening mammography every 2 years. Prior to this, no organization had committed to the 2-year screening interval. Even though there was good evidence that screening every 1 year versus screening every 2 years led to comparable outcomes, nobody was willing to commit to just say every 2 years is okay. So now the U.S. Preventive Services Task Force has committed to every 2 years. Age 40 to 49, so in contrast to what was kind of published in the media or publicized in the media, which was to suggest women in their 40s should not be screened, that is not what the task force says. They say that we should individualize this decision to begin screening according to the patient's context and values. So that means when a patient comes in and she's 41, instead of me just routinely going into my electronic medical record and ordering mammogram, done, here you go, no talk about it, we need to have a conversation about the pros and cons of mammography screening, is she at any particular risk, what's the risk of false positives, and decide with her whether or not she wants to be screened. So that's the recommendation for women in their 40s. For women over the age of 75, they give no specific recommendation. They give it a grade I, which means insufficient evidence. What about breast examination done by a physician or a clinician? So clinical breast exam alone, there is insufficient evidence. Some of the early studies of mammography looked at mammography with clinical breast exam or mammography alone. There are no studies of clinical breast exam alone, so we really don't have evidence to know whether or not that is useful. What about breast self-exam? Many of you may recall there was a time when the American Cancer Society would hand out things that women should put in their shower, and I was trained that you should always be teaching a woman to make sure she does breast self-exam at every visit. There was actually a very large study done in China where women were randomized in factories to either get training about doing breast self-exam or training about back pain prevention. And they basically found there was no reduction in mortality. And as you can imagine, the women who were doing more breast exam, there was a higher rate of benign breast biopsies. They were finding more things by doing the breast exam, and there were more biopsies, but there was no reduction in mortality. So the U.S. Preventive Services Task Force recommends against teaching women to do routine breast self-exam. So I promised you that I would tell you other recommendations besides the task force. So here's the American Cancer Society. Begin mammography at age 40. No discussion, no chit-chat, no pros and cons, just start at age 40. Clinical breast exam at least every 3 years for women in their 20s and 30s, annually for women age 40 and over. In contrast to their prior recommendation of teaching all women to do breast self-exam, they now recommend that women should be informed about the benefits and limitations of breast self-exam, reminding them that if they have any breast symptoms, they want to be sure to report those very promptly. And if they are doing it, we want to make sure they're doing it correctly, but it's okay not to do it. And that women should be informed about the benefits, limitations, and potential harms of routine screening. For older women, and there's a lot of discussion about when we should stop screening for a variety of different cancers, they say that mammograms should be continued regardless of age, as long as she doesn't have any serious conditions that would preclude her from having treatment or wanting to have treatment. And that age alone should not be the reason to stop having regular mammograms. So it's not, sorry, you know, you're 75 now, we're done, but let's look at what other medical conditions you may or may not have, what's your expected life expectancy, would you want to have surgery, chemotherapy, radiation, and make a decision based on that. For high-risk women, women with certain risk factors, and this is a very small minority of women, should get an MRI and a mammogram every year. And these are women who, for a variety of reasons, have a lifetime risk of breast cancer of 20 to 25% or greater. So this is not going to apply to the vast majority of women. And women who have a lifetime risk of breast cancer of less than 15% should not receive MRI screening. So I told you age and mammography, the biggest risk factor for getting breast cancer is age. Younger women have denser breasts, and a lot more false positives in a low-risk, low prevalence population. Looking at this, you can see when you look at breast cancer mortality from mammography screening trials for women in their 40s, 50s, 60s, and 70s, there is indeed a risk reduction for women in their 40s and for women in their 50s. But because the incidence is so much lower, you have to invite almost 2,000 women to be screened to prevent one breast cancer death for women in their 30s, in contrast to women in their 60s, where you only have to invite less than 400 women. So a lot of it really has to do with the prevalence of the disease in younger women. This was an interesting study published last year, which really helped us think a little more, not only about the benefits of screening mammography, but about the potential harms of screening mammography. And the aim of this study was to look at sort of all the available evidence to think about when we're screening women, how do we sort of quantify the risks and benefits when we have a conversation with them about deciding whether or not to be screened. So they looked at reduction in breast cancer deaths. So as you know, that's the most important outcome. But they also looked at what's the rate of false positives and what's the possibility of overdiagnosis. And again, overdiagnosis is finding those cancers that probably never would have been found, except that the woman hadn't had a mammogram. So if you looked at 1,000 40-year-old women who were screened with annual mammography for 10 years, so this is according to the American Cancer Society recommendations, you have 1,000 women, you would have about between 0.1 and 1.6 would avoid dying from breast cancer of those 1,000 women. Between 510 to 690 of them, at some point over that 10-year period, would have at least one false positive. 60 to 80 would have to have a biopsy to evaluate that false positive. And up to 11 women would be overdiagnosed and potentially receive unnecessary treatment. So this is just sort of putting in context for women in their 40s, again, the lowest risk group, what are the potential benefits and what are the potential harms? So the take-home message is that decision-making regarding mammogram screening should be highly individualized and should take into account the range of possible benefits and possible risks. I was asked tonight to tell you a little bit about a trial that's about to start here at UCSF called the Athena Wisdom Trial. And the goal of this study is going to be to attempt to end this whole controversy about what we should be doing for women in their 40s by doing a trial that compares a very common approach, which is annual screening starting at the age of 40, to a more personalized approach. And they're looking at whether or not women prefer this approach and what are the outcomes with respect to breast cancer and mortality. Women in this study can choose whether or not they want to be randomized, and if they do get randomized, they'll either get randomized to having some genetic, more personalized approach versus a standard approach. A pilot study will start at UCSF in 2015. So moving along, we talked about mammography. What about additional screening modalities? What about MRI? Is there any role for MRI in breast cancer screening? What about ultrasound? Some of you have probably heard the conversation about whether we should be adding ultrasound screening to mammography, and then a relatively new technique called tomosynthesis. So the question of MRI is whether it might have a role in screening for high-risk women. And the potential benefit of MRI is that it's not influenced by breast density. And if any of you have ever seen pictures of MRIs, it basically looks like a photograph of everything that's there. The benefit is that it's not influenced by breast density. The downside is that it shows everything, maybe things that you didn't even want to see, but then you have to go evaluate those. It's also very expensive. This was a study looking only at high-risk women, some of them who were carriers of the BRCA1 and BRCA2 mutations, and women who had a lifetime risk of breast cancer of 15% or more. And they found, as you might imagine, that MRI was much better at finding cancer in terms of sensitivity for finding cancer than any of the other modalities, but its specificity was less, which means that a lot of people who didn't have cancer were inappropriately identified as potentially having cancer and had to have a lot of tests to figure out that they really didn't have cancer. So tomosynthesis is a new 3D technique that can be added to mammography. So it's sort of looking at the mammogram in one additional dimension. The goal is to, if you look in another dimension, to make the invasive cancers more obvious and to decrease the false positive rate. As you might imagine, more views gives you more radiation, but it's still well below the FDA-defined limits. So this was a study looking at digital mammography, which is what we do routinely now, alone, versus digital mammography with tomosynthesis. And the study was done before and after the introduction of tomosynthesis at a variety of different settings. And the outcome, of course, that we would like would be mortality. We want a decrease in mortality, right? That's the perfect study. This, of course, was a smaller, shorter study. So what they looked at as recall rate is how many women do we have to come back for additional screening. cancer detection, and the positive predictive value, which is what percentage of women who had to come back for an additional test really had cancer. So they found a decrease in the recall rate with 3D. So that's good. You have to have fewer women coming back for additional testing. They found an increase in biopsies with 3D because you're looking around, you find more stuff. But more importantly, they found an increase in cancer detection. So they found more cancers with 3D. And what we really care about is invasive cancers. Not the non-invasive tend to be the more overdiagnosed ones. So an increase in invasive cancer and the positive predictive value, the percentage of women for recall and biopsy were both improved. So overall, this isn't what we care most about. What we really care about is mortality, but these are all very promising outcomes. So the addition of tomosynthesis is associated with a decrease in recall rate and an increase in cancer detection rate, but what we really want to know is the impact on clinical outcomes, and we don't know that yet. So 40 to 49, shared decision making. So I feel very strongly that if a woman comes in age 40 to 49, I need to have a conversation with her rather than just routinely order the mammogram. 50 to 74, screen every 2 years. Age 75 and over, decide with the woman, but probably not if her life expectancy is less than 10 years. We probably don't want to promote self-breast exam, and high-risk women can consider an MRI. In terms of primary prevention, so screening is what we call secondary prevention. How can I find something early? But wouldn't we like to know how I can prevent it in the first place? That's primary prevention. So there's some evidence that women who drink more than 2 alcoholic drinks per day are at higher risk for breast cancer. So that's one thing that women can do to reduce their risk. Some exercise to suggest that regular exercise is associated with a reduction in breast cancer. And then some dietary factors. Dietary factors are a little challenging to know for sure, perhaps low-fat diet, but not entirely clear. That being said, a lot of other good reasons to eat a low-fat diet. Okay, cervical cancer screening. So cervical cancer screening, this is the biggest success story in the history of cancer screening, is the pap smear. 70% reduction in cervical cancer mortality with routine use of the pap smear. HPV, which is human papillomavirus, is a sexually transmitted virus that is the causative agent in the majority of cases of breast cancer, cervical cancer. We're done with breast, okay? Of cervical cancer. Very importantly, many of you probably lived through the era of a pap smear every year, now until forever. Can't get your birth control pills, can't get anything, can't do anything unless you have your annual pap smear. One of the things we've learned is it takes a really long time for cervical cancer to develop, and so we don't really need to be screening every year. And so for the past 20 years or so, the screening intervals for cervical cancer have been lengthening because you don't really have to look that often. The other important thing is that many of the lesions or the abnormalities that are found are going to get better on their own anyway, so why we should go looking so hard for them when they're going to get better on their own has been another important question. So HPV testing, this is kind of the newish thing in the arena of cervical cancer screening. So this is the human papillomavirus. And for many years, this has been used for women who have abnormal pap smears. Additional HPV testing is done to figure out whether they are at higher risk or lower risk. But up until recently, doing it routinely, just when a woman came in for her pap smear, had been a little controversial. But now it's been recommended for routine screening in certain women. It is not recommended in younger women because the prevalence of HPV is really high in younger women. And so it's only recommended for women over the age of 30. So I'm going to focus here on the task force guidelines, which are the ones on the left. The others are very similar. So pap smear every 3 years in women aged 21 to 65. Previously, it used to be related to the age of onset of sexual activity. No more. Every 3 years for women aged 21 to 65. For women aged 30 to 65, if they want to be screened even less often, they can have HPV testing done with their pap smear, and then they can be screened every 5 years. You can stop screening in women over the age of 65. This recommendation has now been out there for 20 years and still not entirely been adopted. This is the one cancer where the incidence rate goes down with age, and so women over the age of 65 do not need to be screened. No HPV screening in women younger than 30, as I mentioned. In women who have had a hysterectomy and who do not have a cervix, they do not need cervical cancer screening. Women with hysterectomies have been screened for a very long time, but they don't need to be screened if they don't have a cervix. This is some joint society guidelines, which are very, very similar, except as you might imagine with most society guidelines, they have a preferred screening option that incorporates HPV testing, but otherwise more or less the same. Okay, that's it on cervical cancer screening. Let's talk about lung cancer screening now. So lung cancer, we all know, #1 cause of cancer mortality in both men and women, and the biggest risk factor, of course, for lung cancer is smoking. For years in the past, men and women, although most of the early studies were done in men, who were smokers used to get annual chest x-rays, and the earlier studies about whether or not this made a difference were inconclusive. So the PLCO, yeah, I was supposed to slow down a little, sorry. The PLCO trial, you'll hear, I'm going to tell you a few pieces of the PLCO trial, but the L part is for lung cancer screening, so it's the prostate, lung, colorectal, ovarian trial. And this was a more currently done study of chest x-rays for lung cancer screening. So the PLCO trial assigned over 150,000 adults aged 55 to 74 to either get an annual chest x-ray every year for 4 years or usual care. They were followed for 13 years, and there was no reduction in mortality, basically no difference. But we, of course, are beyond the era of regular chest x-rays, right? We have fancier ways of looking at people's insides. And so we now are more interested in low-dose spiral CT. So this is a special kind of CAT scan that can scan the lung in less than 20 seconds, which is the amount of time it takes to hold your breath. Doesn't require any intravenous contrast. It gives you more radiation than a regular chest x-ray, but less than a conventional CAT scan. And as you might imagine, it can detect smaller things than a chest x-ray. So this study was called the National Lung Screening Trial, and this really has transformed what we're doing now about lung cancer screening. They had over 53,000 participants who were randomized to either get annual CT or annual chest x-ray. Very important is who the participants were in this study. So they were all either current or former heavy smokers with a greater than 30-pack year history. They were aged 55 to 74. They got the CT for 3 years, and they were followed for 6.5 years. So they looked at our favorite outcome, mortality, the most important outcome, and they found a relative risk of mortality of 0.8, which means a 20% reduction in mortality compared to chest x-ray. So significant reduction in the chance of dying from lung cancer. And never before seen with any other cancer screening test was a reduction in all-cause mortality, 0.93, so a 7% reduction in all-cause mortality. These are the confidence intervals which show you that the true result is somewhere within there. They don't cross 1, and so these are statistically significant. So this was big news, the National Lung Screening Trial. In order to prevent one lung cancer death during the time of the trial, you had to invite 320 people to be screened, and in order to prevent one death from any cause, you had to invite 218 people to be screened. However, this reduction in mortality was balanced by over 75,000 CT scans, over 18,000 of which were positive, over 17,000 of which were false positives, leading to a lot of additional things, including 673 thoracotomies or medionoscopies, which are significant procedures, 303 bronchoscopies, which is a tube looking down into the lung, 999 biopsies, all to prevent 62 deaths from lung cancer. So very, very high false positive rate.
999?
I said 999, sorry, it was 99. I made a mistake, sorry. Got caught up in my nines there. So at least one false positive test in a lot of the CT scans. Question of a possibility of overdiagnosis. There was a higher cancer incidence with CT. So there was a higher cancer incidence, but certainly reduction in mortality. Also concern for radiation exposure. And of course, incidental findings. We'll talk about this more with virtual colonoscopy, but you're asking the radiologist to look at the lungs, but guess what? They can't just look at the lungs. Anything else that they see, they have to comment on. So these are the potential harms. One of the important things here, and this is a huge issue with respect to ongoing policy for lung cancer screening, is figuring out how many people, who is the right person to be screened in this study. So if you look at the typical participant in the NLST, 62-year-old smoker with a 1.5 pack year history, you have to screen 256 people like him. If you look at the minimally eligible participant to be in the NLST, so the youngest with the least amount of smoking, you have to screen over 1,200. There was a local hospital, Sequoia Hospital, which basically let anybody who wanted to be screened be screened. So this was a 40-year-old woman who smoked a little bit, and look how many people had to be screened. So this is very, very important in the policy, which we'll talk about who exactly should be screened. It really depends on how high risk they are. So we talked at the beginning about selective screening, and this is really the critical example of selective screening, because lots of people have smoked a tiny bit at some point in their lives. I will not take a poll, but many people have never ever smoked, but lots of people tried it a little bit for a while, or maybe on and off for a while, but didn't really meet these criteria. So what are the guidelines and recommendations? So these have evolved since the NLST, and we'll focus on the task force, but the first set of guidelines, as they usually do, came from the specialty societies. So they said, I think we should screen those people who meet the criteria, would have been in the NLST if it was being done in their community. So they met the entry criteria, but only if it can be done at specialized centers where they have, thoracic surgeons, radiation oncologists, et cetera. This never really made sense to me, because that would mean I could send my patient, because I practice at UCSF and I have access to all the specialists, but as somebody who practiced, for example, in rural Kentucky, doesn't have access to this, so their patient wouldn't be eligible. So that never really made sense, but those were the initial recommendations. What was the NLST setting? So who were the people, and what kind of setting would it be that people could be screened in? So the vast majority of them were NCI, National Cancer Institute designated cancer centers, just like UCSF, UCLA, mostly large academic centers. All were likely to have all the board certified specialists that they needed. The CT scanners had extensive quality control, and they had an algorithm, a plan. Lots of people have nodules found on chest x-ray or on CT. So for example, if I had a low-dose CT, it's possible I could have a nodule. And there's varying criteria about if the nodule is this size, then you repeat the CT in 6 months. If it's that size, then you have a biopsy. So they had a little protocol for how to manage those nodules, but it wasn't mandated. Some of the nodules, of course, are cancer, but a lot of them aren't. The U.S. Preventive Services Task Force, again, the organization that's really evidence-based, before the NLST, they gave it a grade I recommendation, although they did recommend that physicians do smoking cessation counseling. So as of December 31st of 2013, they began recommending annual screening for lung cancer with low-dose CT in persons at high risk for lung cancer based on age and smoking history. They gave this a grade B recommendation, so grade A is the highest level of evidence, grade B is the next level, and there was a lot of discussion about this, but this is now their recommendation. And I'm sure you're asking yourself, in persons at high risk, who are those persons at high risk? So this is it. Age 55 to 79, so a little older than the people that were in the NLST, but again, age is a big risk factor. Total exposure to tobacco smoke is 30 pack years or more, and acknowledging that those who have quit within the past, if you've quit, but quit within the past 15 years, you're at the highest risk. They also remind us to consider other comorbidities, and this is particularly important in something that affects smokers. So many people that have a heavy smoking history, they may have very bad heart disease, very bad emphysema, maybe oxygen dependent. So we wouldn't be really doing screening because they wouldn't be able to undergo surgery or undergo the treatment. So we really need to think carefully about whether or not this person would be a candidate for additional treatment when we make the decision about screening. And we know how to prevent lung cancer. There's been a lot of discussion about whether or not reimbursement for low-dose CT should be tied into whether or not the person is enrolled in a smoking cessation program. Should we allow them to get screened if they're still smoking? But we do know how to prevent cancer. So what are the implications? Certainly we want to continue, even if a patient is going to undergo low-dose CT, continue to encourage smoking cessation. Very importantly, we need to strictly adhere to those guidelines, and we need to use experienced centers and demonstration projects to ensure quality and effectiveness. Interestingly, Medicare just a couple of weeks ago has now stated that they will cover low-dose CT for high-risk individuals, similar to the task force criteria, but only if they have a visit with their physician that is documented as a lung cancer screening discussion counseling visit, where the physician or the other clinician had a conversation with them about the pros and cons of lung cancer screening. So the physician can't just order it without documenting that conversation has happened. Okay, let's move on to colorectal cancer. So colorectal cancer, a third leading cause of cancer mortality in both men and women, and again, the risk increases with age, and the general recommendations is for routine screening to start at the age of 50, and we'll talk about the screening options. So there's a joint guideline published by a variety of different organizations, and one of the challenges here, there are a lot of options. So FOBT, which is fecal occult blood test, and you take the little kit home and collect some specimens of your stool, put it on a little card, send it back in, it gets checked for blood. So there's either that or the fecal immunochemical test, which is a better way of looking human blood. Flexible sigmoidoscopy, which is a tube that goes up through the rectum and goes up part of the way up through the colon every 5 years. Barium enema every 5 years. CT colonography, which is virtual colonoscopy, which we'll talk about every 5 years. Colonoscopy every 10 years, or stool DNA testing at some uncertain interval. So this is what they describe as their menu of options. And then they say that in the context of the visit for hypertension, diabetes, obesity, arthritis, and depression, that I should make the patient fully aware of the full range of screening options and discuss with them which tests they would like to have, offering them a choice between a test that is effective at both cancer prevention and detection, which would be a test that could remove a polyp, so like a scope-based test, or one that is only effective at cancer detection, which is a stool-based test. And they say that colorectal cancer prevention should be the primary goal. So you have all these options, but these ones are preferred based on this guideline. The U.S. Preventive Services Task Force recommends that we routinely screen from age 50 to 75, and again, that the age situation comes in here again. Individualized decisions from age 76 to 85, and no screening after 85. And they recommend that there are fewer acceptable options. So colonoscopy is one. Fecal blood test is another, either the FOBT or the fecal immunochemical test, or sigmoidoscopy. In contrast to the joint guideline, which has all those other options, the task force says that there's insufficient evidence for CT colonography or fecal DNA. And very importantly, and in contrast to I think what the perception is out there, the Preventive Services Task Force does not recommend a preferred test. Every time they revise their recommendations, we wonder if they will recommend a preferred test. They do not recommend a preferred test. Fecal immunochemical testing, I alluded to this. This actually uses human antibodies to help us find human blood in the stool. Some of you might recall, and again, I won't ask for a show of hands, but doing the FOBT test where you had to collect 3 specimens and you had to change your diet, stop your aspirin, stop your medications. It was kind of more complicated. You don't have to do that with the FIT test. It's just a single test, and it's a little less specific than FIT, but a little FOBT and a little less specific. This is what we routinely use at UCSF. It's a little more expensive than FOBT, but many places are transitioning toward using it. But we can just consider it as one of the stool test options. Colonoscopy, the American College of Gastroenterology has guidelines. Just to be clear, they are the one and only organization that says that colonoscopy remains the preferred colorectal cancer screening strategy. So no other organization recommends a preferred strategy except the American College of Gastroenterology. I think the perception out there is that colonoscopy is the test and there are no other alternatives, but I think it's important to recognize that there are other alternatives, and the only organization who chooses colonoscopy as the one is the American College of Gastroenterology. There has never been a completed randomized controlled trial of colonoscopy. Colonoscopy was an integral part of the trials where people did stool tests. And so the stool test, as you probably know, the FOBT or the FIT test, if that test shows blood, then what happens? Colonoscopy. So the colonoscopy was a part of those trials, but were never studied alone. There are a few ongoing studies of colonoscopy versus either FIT testing or CT colonography, but we don't have those results yet. Sigmoidoscopy really has fallen out of favor, I think, but used to be more routinely done. Primary care physicians used to do it in their office. As you know, the sigmoidoscopy looks half the way up, the colonoscopy looks all the way up, but the sigmoidoscopy, you don't have to get sedated, you can go home after the procedure. There is evidence that there is a reduction in colorectal cancer mortality shown in the C part of the PLCO trial. This is the colon cancer screening part. So the mortality reduction, though, as you might imagine, is limited to those cancers that the sigmoidoscopy can reach. So as you probably know, the colon is kind of an upside-down U, horseshoe-shaped, and when you go into the rectum and go half the way up, that's called the distal part. So the mortality reduction is only in that part that the sigmoidoscopy can reach. Another study looking at one-time flexible sigmoidoscopy did show that that could reduce mortality as well. Again, not as commonly used. In the United States, looking over time, the reduction in use of sigmoidoscopy, very few primary care physicians are recommending it, and colonoscopy recommendations have skyrocketed. That being said, we're in San Francisco where probably most people can get a colonoscopy if that's what they choose from their insurance perspective, but in many underserved settings, you know, county hospitals and other places where there are fewer gastroenterologists, it may not even be an option. So let's talk a little bit about virtual colonoscopy and stool-based molecular testing, or fecal DNA. So virtual colonoscopy, you've probably heard about. It's a non-invasive radiological technique. It has a radiation dose similar to barium enema. Barium enema is very uncommonly done now, but in the past was done where some barium was inserted into the rectum and special x-ray pictures were taken. The bowel preparation is similar to colonoscopy. Again, I won't take a show of hands, but I will say, based on what patients tell me, that the worst part, or one of the big barriers to having a colonoscopy, is the prep. I'm seeing nods, I won't point any fingers, but many people find the prep challenging. You have to drink this liquid, and then you have to be near a bathroom for half a day before the procedure, and it's a limitation. So currently for virtual colonoscopy, you still need to do the prep, although there is a prepless technique being evaluated. It doesn't require sedation. The colon has to get distended with air, and you have to hold your breath. And guess what if they see polyps? You still have to have a colonoscopy. So for some people who want to avoid the colonoscopy, if polyps are seen, depending on the size and so forth, they may have to have the colonoscopy anyway. Laxative-free CT colonography is being evaluated. So this was a special kind of processing software that did what they call electronic cleansing, which is different than the usual cleansing. And they had adults undergoing regular colonoscopy, optical colonoscopy versus virtual colonoscopy. And they found that it had good accuracy, and no big surprise, patients preferred it. So keep on the horizon for the future. What are the potential harms of virtual colonoscopy? So again, radiation. We're very concerned about being sure that we don't expose people to any additional radiation. Procedure-related harms we always have to think about, but certainly significantly lower than colonoscopy. But very importantly, and I alluded to this with lung cancer, is the possibility of extracolonic findings. So that means, you know, you told the radiologist, I'm doing a colonoscopy to look at the colon, but they see other stuff, and they can't ignore it. So lots of stuff gets seen, most of which is probably not that important, but there's some small percentage, between 5 and 11%, of things that are found that are of potentially high clinical significance, where they might either need additional treatment or additional imaging. A fair number of people, between 7 and 16%, need some kind of additional evaluation for these extracolonic findings, but very few of them ultimately require definitive treatment. Fecal DNA testing is a special kind of test looking for DNA mutations in the stool. The potential advantage is that it's not invasive, doesn't require any preparation, and allows for detection along the whole length of the colon. This was a big, large, multi-center study. This was initially done looking at patients with colon cancer, but this was looking at average risk adults. They found that fecal DNA could find more, was more sensitive, so better amongst those people who had the disease at finding neoplasms or cancer than FIT. But again, anytime anything's more sensitive, you tend to have a lot more false positives. And so the sensitivity was a lot higher, but the specificity was lower. So we've talked about all the pros and cons of the various different tests, and I think so often we get caught in the details of the different tests that the big issue is, are people getting anything done? So this is looking at anybody who has had a stool test in the past year or any kind of oscopy, colonoscopy, sigmoidoscopy in the past 10 years. So this is a pretty generous definition of colorectal cancer screening. If you look at from 2002 up to 2012, we are heading in the right direction. We're certainly making improvements from 54% up to 65%. But if you were to look at comparable numbers for mammography or cervical cancer screening, we're usually at 80 to 85%. So we've made progress, but we still have a long way to go. So in conclusion, we've talked about all the different tests and all the different options. The bottom line is that any screening is better than no screening for reducing colorectal cancer mortality. We need to remind people of the importance of getting screened. Virtual colonoscopy and fecal DNA are options in the joint guidelines, but not in the task force. In terms of what physicians should do, we should certainly make sure that we offer the testing, and you can also come in and ask for it. And once in a while, patients do come and tell me they're due for their colonoscopy, but other times they don't. The stool test is certainly a reasonable option. FlexSig, probably much less routinely performed than it used to be. CT colonography is currently not routinely reimbursed by Medicare. And the bottom line is that rather than only to, from my perspective, rather than to only talk about colonoscopy, is to talk to the patient about which test he or she would like to do and make sure that he or she gets the test. But again, if the person chooses to have the stool test instead of the colonoscopy, have to remind them that if that test is positive, they still have to have the colonoscopy anyway. Okay, so let's turn to prostate cancer. And in contrast to colorectal cancer, where the question was what tests we should do, the question for prostate cancer is really, should we screen at all? So if we go back to sort of our screening criteria, first, does the disease have high prevalence? And the answer is yes. Men have about a 10% lifetime risk of developing prostate cancer. And about 30% of men will have prostate cancer at autopsy. However, they did not die from the prostate cancer. It was often incidentally found at autopsy. Our next sort of category is, does the disease have serious consequences? And sometimes it does, but for many men, prostate cancer can be a very benign disease. And right now, we don't have a good way of determining for which men it will be more aggressive versus for which men it will be more benign. Is there this detectable preclinical phase, a time during which you can find something before the patient has any symptoms, and question mark PSA, and we'll talk a little bit about PSA. PSA stands for prostate-specific antigen, which is a blood test, and we'll talk a lot about that. Is the treatment for preclinical disease any more effective, which is another very important question. And it's important to recognize that there are a significant number of complications from the treatment of prostate cancer, specifically incontinence and impotence. But again, our first question is, does screening reduce mortality? So PSA testing sort of came into be in 1988, and as is often the case, is once a test is there, it starts getting used. And so it's really increased dramatically since it was first introduced in 1988. Observational studies. So observational studies is basically looking at a group of men in a population, seeing what they do, whether they got screened or not, and following them forward. So you're not intervening, you're not assigning them to get screened or not screened, but looking at them and seeing them forward. And they've had conflicting findings about the benefits or not of prostate cancer screening. But there have been 2 large randomized controlled trials of PSA screening and mortality. So the P part of the PLCO, the prostate, lung, colorectal, ovarian trial, over 70,000 men were randomized to either get PSA for 6 years plus rectal exam for 4 years versus usual care, which is going to your doctor and getting whatever he or she recommends. Very importantly, because we were in the era of everybody getting PSA testing in the community, there were very high rates of screening in the control group. So the group that was assigned to usual care, a lot of them were getting PSA tests anyway. There were no significant differences in death between the two groups at 7-year follow-up. You look at the number of deaths per 10,000 person years in the two different groups. And at 10 years, same thing. So all this screening and no reduction in mortality at 7 to 10 years. There was a similar trial done in Europe, over 182,000 people. It was done in 8 different European countries. All of the countries had different protocols for when and how the PSA screening was done, but it was basically done at least once every 4 years versus no screening in the different countries. During the 9-year follow-up, the incidence rate was higher in the screen group. Now that should not surprise us, because if you're doing a test to look for something in some people, you're going to find more stuff. So we shouldn't be surprised that the incidence was higher. The mortality was lower in the screened group. 7 fewer prostate cancers per 10,000 screened men. And so in order to prevent 1 prostate cancer death at 11-year follow-up, 1,410 men needed to be screened and 48 additional prostate cancers treated. So that's a lot of screening, a lot of prostate cancer treatment to prevent 1 death. So what are the conclusions based on those 2 big randomized controlled trials? So PSA screening may lead to a modest reduction in mortality, but in order to achieve this mortality reduction, there's a substantial amount of overdiagnosis and overtreatment. So again, we'll start with the U.S. Preventive Services Task Force. So prior to 2012, they gave it a grade I, insufficient evidence recommendation. In 2012, they recommended against PSA-based screening for prostate cancer. Do not screen. This was a huge news. Grade D recommendation, don't do it. They acknowledged that PSA can detect early prostate cancer. Again, the more you look, the more you find. But there was really inconclusive evidence about whether or not this early detection could improve health outcomes. And they acknowledged a lot of potential harms. So frequent false positives, unnecessary anxiety, biopsies, and potential treatment of cases of prostate cancer that may have never affected the patient's health. So they recommended against screening for prostate cancer. The American Cancer Society had a different view. So they recommend that men who have at least a 10-year life expectancy, so if you're kind of hearing this theme about the 10-year life expectancy, that if we're going to screen and potentially think about surgery, various interventions, it makes sense to think about people who are expected to live for a certain period of time. Men with at least a 10-year life expectancy should have an opportunity to make an informed decision with their healthcare provider about whether or not to be screened. Very importantly, screening should not occur without an informed decision-making process. So I should not just enter in PSA in my electronic medical record without having a conversation with my patient about the pros and cons of prostate cancer screening. Men at average risk should start getting this information starting at the age of 50, and if men are at higher risk, we should think about doing it earlier. And if a man can't decide, then the decision can be left to the discretion of the healthcare provider. Men with less than a 10-year life expectancy should not be offered screening, and they remind us that at the age of 75, only about half of men have a 10-year life expectancy. Maybe I shouldn't have said that. For those who choose to be screened, PSA, the blood test, with or without DRE. And DRE, who knows what DRE is? Digital rectal exam. So that was another sort of standard for over the years of doing this test, which is a rectal exam to feel the prostate. And the Cancer Society says do the PSA with or without the rectal exam, although there's no clear evidence that the digital rectal exam is useful as a screening test. Then, depending on what the PSA is, will determine whether or not, when we should repeat it. The American Urological Association, as you might imagine, has a very different perspective. So when the U.S. Preventive Services Task Force published their guidelines, and the way their guidelines work is they published a draft, and then they allow for public commentary, and then they can amend it and publish their final recommendation. So the American Urologic Association was outraged at the task force failure to amend the guidelines. Men who choose to be screened should have both digital rectal exam and PSA. They do acknowledge that the decision to use PSA testing should be individualized. We should inform men of the potential benefits and risks, and that we should offer this discussion to all men over 40 who want to be screened and who have the 10-year life expectancy. So then the American College of Physicians, which is the organization of internal medicine physicians, came into the fold to make their commentary. And instead of making up their own new guidelines, they formulated what they call a guidance statement, where they put sort of all the recommendations together. And their recommendation is that we inform men aged 50 to 69 about the limited potential benefits and substantial harms of screening, making sure that we talk about risk for prostate cancer, benefits and harms, in contrast to the Cancer Society, who says if the man can't decide, then the doctor gets to decide. The ACP said if the man doesn't have a clear preference, don't do it. Do not screen average risk men who are under age 50 because their risk is low, over age 69, or yeah, we're going to skip that life expectancy thing because you don't like that so well. Okay. So, in summary, PSA testing may reduce prostate cancer mortality, but it's not recommended by the U.S. Preventive Services Task Force. There are significant risks to early detection and treatment, and shared decision making is key. The last cancer we're going to talk about is ovarian cancer screening. So again, the question, similar to that for prostate cancer, is should we screen? The major issue with ovarian cancer has to do with our first screening principle, which is prevalence of disease. Thankfully, ovarian cancer is a very, very rare cancer. So an average woman has a lifetime risk of ovarian cancer of about 1%. Some women with hereditary syndromes or family history are at higher risk, but overall risk is relatively low. And as you know, when you're screening up for a low prevalence condition, you're going to have a lot more false positives. However, we also know that if one can find ovarian cancer when it's limited to the ovaries, that the survival rate is much higher. So theoretically, we would like to be able to do that. So what are the potential ways that we might screen for ovarian cancer? So there's a blood test called a CA-125 test. This is used to monitor treatment of women who have ovarian cancer, and it's been proposed for use as a screening test. Pelvic ultrasound, which is a way of looking at the ovaries, and pelvic examination. And I will acknowledge that there's no evidence that pelvic examination is useful as a screening test for ovarian cancer, which is why in the PLCO study, they actually took it out as part of the screening protocol. So this is the O part of the PLCO trial, where they randomized over 78,000 women to either get screening or usual care. Those who were in the screening group got annual CA-125, the blood test, plus an ultrasound. And if either the blood test was elevated or the sonogram was abnormal, then that was considered a positive test. Any positive test was then followed up by the person's physicians, and they were followed for over 12 years. And what did they find? So they had the screening group and the control group. So first of all, in the ovarian cancer diagnosis, there were more ovarian cancers diagnosed in the screening group than in the control group, with a relative risk of 1.2. That, again, should not surprise us. They were searching for ovarian cancer, right? They're doing all these extra tests, so it shouldn't surprise us that they found more. However, when you look at mortality, there were actually more deaths in the screen group than in the control group, not statistically significantly different, so certainly did not reduce mortality. And there were over 3,000 women with false positive tests, over 1,000 of whom required surgical follow-up. So they came in for screening, they have an abnormal test, they then have to go to surgery to find out that they didn't have ovarian cancer, and there were 163 serious surgical complications. So there were some significant negative consequences to this screening. So the conclusion is that annual screening for ovarian cancer with CA-125 and ultrasound does not reduce disease-specific mortality, but it does increase medical procedures and associated harms. So getting back to primary prevention, what can a woman do for primary prevention of ovarian cancer? So for women who are at particularly high risk for ovarian cancer, during their reproductive years, using oral contraceptives for as long as is feasible is associated with a reduction. Being pregnant, there are many other reasons for being pregnant, but if a woman has been pregnant, a few times, that is associated with a reduction in ovarian cancer. And the longer a woman breastfeeds, the lower her risk of ovarian cancer. So screening for ovarian cancer is not recommended for average risk women. However, women who are at high risk for ovarian cancer may consider oral contraceptives, or in some situations, women at particularly high risk may consider oophorectomy. So in summary, women aged 50 to 74 should undergo mammography every 2 years. Screening for breast cancer for women in their 40s and for women aged 75 and over should be individualized. All men and women aged 50 to 75 should be screened for colorectal cancer with something, and any screening is better than no screening. Cervical cancer screening can be done less frequently than previously recommended and can incorporate HPV testing for some women. The U.S. Preventive Services Task Force recommends screening high-risk individuals for lung cancer. Screening for prostate cancer is not recommended by the U.S. Preventive Services Task Force, but a shared decision-making approach is recommended by other organizations. And finally, ovarian cancer screening is not recommended for average-risk women. So in summary, today I ate 2 bowls of dog food, a sandwich crust, some spaghetti that fell on the floor, half of your cat food, a wet tea bag, 3 bugs, and the inside of a sneaker. How many grams of fat is that? So with that, we'll stop and take some questions. Yes, first question. So I'm glad you've answered 2 questions that I can so easily answer in the next 2 minutes. So the first question was about chemicals in the environment and their association with cancer and what we're doing about that. And the second question was what are we doing, what am I doing, what are we doing to help people stop selling cigarettes in the world? Okay, so easy question. So the first one about the chemicals. Like the chemical one is a very complex situation and difficult to sort out because these are exposures over time, and it's really hard to be 100% sure that we know what the chemical associations are and what to do about them. And there's a lot of associations in the literature, but associations don't always equal causation. And so this is not the chemical thing, but for example, the evidence for alcohol, the evidence for hormone therapy, even that, how much a woman drinks on an average day and how long she took hormone therapy and so forth. So I think the chemical issue, it's kind of in and it's out there, but it's a very difficult one to measure because it's really hard for us to measure how much am I exposed to versus how much are you exposed to. And I think it's probably, if there is an association, it's not clear how big an association that is, because if you look epidemiologically across countries, I mean, there is breast cancer in all these other countries. That's number one. Number two, smoking. I mean, that's a whole big policy issue. I mean, I think if we look over the years, a lot of things have been done to discourage smoking. It's really hard to smoke in any public place. The cost of cigarettes has gone up significantly. As we all know, it's an industry and it's hard to get rid of entirely. There's any ad for smoking, well, all these things where the ads, tell you it's bad for you and so forth. Short of outlawing it, which I think would be very complicated given that tobacco is a big industry, I don't know that we can necessarily stop it. I think you're right that it is a bigger issue in a lot of subpopulations. So for example, in the Vietnamese community, and in some communities it's still considered not, sort of a good thing to smoke, or it's not necessarily a bad thing to smoke. I mean, I know my children, when they were young, we were out somewhere, and I was really embarrassed. Look at that man, Mommy, he's smoking, that's so bad. And I had to, kind of, we're at Costco, and we don't really want to. But they had gotten the message at this young age that this is not an acceptable behavior in society. But in other parts of society, I don't know that message is as strong. So I cannot solve that tonight, but if anyone else has any solutions, we would welcome them. Yes. So the question is about the fecal DNA testing as a stool test and how prevalent it is. So it's been studied, it's approved, it's very expensive, it is not routinely used, and it hasn't been studied in terms of the mortality reduction thing. It's been studied in terms of test characteristics, comparing it to other tests. I bring it up not as a recommended go change your screening procedure thing, but because if I don't bring it up, somebody will ask, why don't you talk about the fecal DNA test? Haven't you heard of the fecal DNA test? So the idea, DNA is kind of the thing now. I mean, you can really find the DNA, and that's important, and we can find these mutations associated with colorectal cancer. So it is another way that has been shown to reduce colorectal cancer, not mortality, but it's been shown to have certain set of test characteristics. So it's not routinely recommended by the evidence-based organizations. And I don't think it should change your life right now. The one thing I should add, which is a little related to your comment, because this comes up often, is that if a person gets a colonoscopy and it's normal, they're home free for how many years? 10 years. And guess what? No stool tests in between. There's kind of this practice out there about doing the stool tests in between. Nothing in between. You're home free for 10 years. And that's it. No stool tests in between. You didn't ask that, but I just felt compelled since you asked about stool tests. Yes, in the back? So your question, I think, is that you're advised to, report any unusual things to your healthcare provider, which is true. But screening is a different issue because screening is independent of any symptoms that you have. So let's say you come to me with a cough and weight loss. I say to myself, this could be lung cancer, right? This man smoked for X number of years and he's coughing and he's losing weight. So I'm pursuing a diagnostic evaluation for lung cancer. But if you come to me and you say, I smoked for 30 years and I quit last week, but I feel fine, but I wonder about that new test, and we're doing it as a screening procedure. So I think we certainly need to pay attention to symptoms and then decide what to do and work with your healthcare provider to decide what to do. But screening really is about when you feel fine, what test do you need? Yes. So the question is, if the incidence of colorectal cancer increases with age, then why do we decrease screening at the age of 76 to 85? So first of all, every single one of these cancers, except cervical cancer, the incidence increases with age. So for all these, the biggest risk factor for any disease practically, except cervical cancer, is getting older. It is. So, and as I say to my patients, as we all get older, this is what happens. So the flip side of that, though, is routine screening, in age 50 to 75, and then 76 to 85, it's more sort of an individual thing. So there are some 76-year-olds who are very healthy, very vital. Maybe they have high blood pressure, but they're out and about, coming to UCSF mini medical courses, taking notes, asking questions, going out for coffee with their friends. And there are other 76-year-old people who are very overweight, have heart failure, have emphysema, have other significant medical problems. And so the decision to screen is not just, oh, she's 76, we're done. It's, she's 76, but how does this fit in the context of all her other medical problems? Would she be a surgical candidate? Would she undergo chemotherapy? Would she want this? Would she not? So it's more about the individualized decision based on how well or sick the person is, and also what they would want. And so there's some 80-year-olds where I would screen them, because they are vital and healthy, and there are some, 65-year-olds who I would say, gosh, I don't think it makes sense to do this, because would you really want to have surgery, or would you really be able to undergo surgery? Yes?
How harmful is secondhand smoke?
How harmful is secondhand smoke? So I can't quantify it. I mean, it's harmful. It's not as harmful as firsthand smoke, but it's not good for you either. In terms of, I think we know more about it in association with asthma and other lung conditions than we do in association with cancer, but it's certainly not good for you. And it's often a reason that we try to get the smoker to quit is, for example, parents who have children with asthma and the parent smokes, it's like a guilt thing, is that's how you get the parent to quit smoking, as you say, it's making the child's asthma worse, because it probably is. So it certainly is bad, but not as bad as firsthand smoke. Yes? So why isn't family history a factor for PSA testing? So family history does increase your risk of prostate cancer, but it's not recommended that high-risk people or low-risk people be screened for prostate cancer. So you're absolutely right. The risk is increased with family history. Risk is also increased in African American men. But even if the risk is increased, if screening doesn't work, or if screening doesn't seem to lead to improved outcomes, then it's not recommended in any group. So that for prostate cancer. Some men may choose to be screened because they feel they are at higher risk, but the question is, if you're doing a screening test and there's not a clear evidence that mortality is reduced or that mortality might reduce to a small amount, it really doesn't matter if you're higher risk or lower risk. So it is a risk factor. And one of the big issues when the Preventive Services Task Force published their guidelines, and then they had this 6-month period for public commentary and revising, people thought they might revise it, for example, for African American men who are known to be at higher risk. But there's not really any evidence, even though they're at higher risk, that therefore the treatment would be better for them. Yes, in the back. There's a light back there. I can see a hand, but I can't really. So the question is there any benefit to having a FIT test in between colonoscopies if the person has had a polyp? So if the person has a polyp at colonoscopy, it's typically removed, and it's sent to the laboratory, and it's determined what type of polyp it is. If it's a non-concerning polyp, then the screening interval doesn't change. If it's a polyp with adenomatous features or some concerning polyp, then the typical rescreening interval is sooner, either 3 to 5 years. So what changes is when the colonoscopy gets repeated, but there's really not a utility in doing FIT in between. Yes? Does it matter? So the question is about the ability to compare mammography over time and whether or not that means the screening is better or not. So mammography is done at some interval, either 1 year or 2 years, and but many women have mammography done frequently. Very importantly, it's important to be able to compare if you have a mammogram today and something abnormal is seen on it. Then the radiologist can look back and say, look, she had a mammogram 18 months ago. Was that there? Does it look the same? Does it look different? So it can kind of be useful in comparing changes or seeing if something that's there now was there before. So it's certainly helpful in comparing changes over time, but I don't think there's any evidence that, that the cumulative mammography is better or worse than a one-time mammography. But certainly it's a very important thing is to be able to compare. And when I have a patient who comes in who's getting her mammogram, who said, well, I used to get my mammograms at this place, and I used to have this thing on my left breast that they looked at, whatever. I said, before you even schedule your mammogram, bring your old films in with you and have them there for radiology. So then we don't get the phone call about, oh, there's an abnormality on the left breast. We want to take a closer look over time. But so it's very important in terms of comparing any abnormality that's seen. Yes?
Mammograms have to be so painful?
Do mammograms have to be so painful? I had a little cute little story I used to include one time about the painfulness of mammography. But in order to get a view, sometimes a certain level of compression needs to happen. So I'm not aware of a way to make that less uncomfortable. For some women, it's more uncomfortable than other women, but a lot of it depends on sort of being able to get a good view of the tissue. So, yes.
Does BPH change the PSA?
That is an outstanding question. So the question is, does BPH change the PSA, or does BPH in any way affect how you think about screening for prostate cancer? So probably many people know what BPH is, but for those of you who may not, it's called benign prostatic hypertrophy. It's a very common condition as we all get older, is how I like to say it. But as men get older, the prostate gets larger, sometimes can compress on the urethra, and men have to urinate more frequently and not have the strongest stream and so forth. So there's been a lot of question about whether or not those symptoms are in any way related to prostate cancer, number one, or whether they can increase the PSA. So because those symptoms are so common, they're not really predictive of prostate cancer, number one. Size of the prostate is associated with a higher PSA value, and so that's yet another one of the confounders in the equation about checking PSA, because if a prostate is bigger, there's going to be more PSA, and hypertrophy means getting bigger. Let's see, yes. So how does a man determine he doesn't have an aggressive form of prostate cancer without having a PSA test? Well, first of all, a man may or may not, he has prostate cancer at all before having a PSA test. That is the key question would be if we had a way of determining which cancers were more aggressive versus not. I mean, some men have symptoms, some, that would help to find. There are other ways of finding prostate cancer besides screening. But in order to determine the aggressiveness, you have to have a biopsy. And obviously you don't get to a biopsy unless either you have screening and an abnormal screening test, or you have some kind of symptom that led to the biopsy. But then the question is, which one's more aggressive and which one's less aggressive. And PSA does not really predict which one is more or less likely to be aggressive.
Get to the biopsy without the PSA test.
How would you get to the biopsy without the PSA test? If you had symptoms that you told your doctor about, and your doctor did an evaluation for some kind of symptom.
But most men getting the PSA test don't have symptoms.
Well, not necessarily. I mean, if the PSA test is done for screening, but a PSA test could be done in a man who had symptoms too. So PSA test can be done for more than one reason. Yes?
Are digital mammograms used mostly now?
Are digital mammograms used mostly now? We really have evolved more to using mostly digital mammograms. UCSF uses them, and probably 10 years ago it was less that they were used routinely, but now digital mammograms are used routinely.
Is there a difference between that and the regular?
Digital mammography, is there a difference between digital and film mammography? Digital mammography is a little more sensitive, particularly for younger women with denser breasts, but now it's kind of really has become the standard of care. And yes, so that is a great question. That'll be our final question, since we start with a hard one, we end with a hard one. So the question is, if you look at the genome, is there a genetic imperative for cancer? So the genome is, kind of a whole big area of interest now, and there are lots of different mutations associated with lots of different things. Research going on all over this campus looking at that question. There's not like a single thing that says you are going to get cancer or you're not going to get cancer. I mean, one thing, as we have improved treatments for a variety of things, heart disease being the primary one, infections, years ago used to be a bigger cause of death than they are now, then people live longer and develop other things. But I wouldn't say it's not as simple as, you got the cancer gene, so, it's going to get you. So anyway, I think with that we'll stop, and others can discuss the genome.